So now we're going to take a look at the questions from the fourth exam. The topics have been chosen because they've cropped up in relatively recent times. The topics have in the BSc exam, so they're topics you should make sure you're au fait with. The first 5 questions, as usual, are physics based, and the rest are more general questions. So, regarding the produced signal, decibel is a direct measure of the power of the beam. No, decibel is a relative measure, so it measures how much louder the beam is than a reference value, so that's false. Decibel is measured in pascals, that's false because it's a ratio, so it's a logarithm of a ratio in fact, so there's no units associated with it. To use the decibel scale, a reference is required. That's correct, because you choose a reference level of sound and say how many, effectively the number of decibels is the logarithm of the number of times louder your sound is in the reference. Typically modern transducers are broadband transducers with a bandwidth comparable to centre frequency. That's true, that's something you should just remember, those words, and it's to allow multi-frequency imaging. Broadband transducers used for contrast enhanced imaging is true. TDI. ECG optimization is more important for TDI than for conventional 2D imaging. That's true for a number of reasons. Most obviously because many of the things you measure in TDI are not just the size of velocities, but when the velocity happened, and therefore you want to know how long after a signal, a fixed point in the cardiac cycle, the velocity happened. And the obvious fixed point to choose, or the easiest fixed point to choose, is the ECG signal. Typically blood and tissue velocities are 2 orders of magnitude different. Remember, 2 orders of magnitude means, or 1 order of magnitude means 10 times, so 2 orders of magnitude means 100 times. So, blood moves at a few centimetres per second, tissue moves at a few centimetres per second, blood moves at a few metres per second, so that's roughly 100 times different, so that's true. The spatial velocity gradient is relevant to the calculation of strain rate. We talked about how strain was calculated from tissue Doppler in the course. If you remember, we took 2 velocities at the 2 ends of a bar of muscle and said the strain would be, or the strain rate more specifically, would be calculated by a difference, whether the velocities were different or not. If they were the same, the 2 ends of the bar of muscle were moving at the same speed, and therefore the bar wouldn't be getting longer or shorter, therefore the strain and the strain rate would be 0. If they're moving at different speeds, it would either be getting longer or shorter, because one end was moving at a higher or lower speed than the other end of the bar of muscle, and therefore the strain would be positive or negative. So really what we're calculating is what the difference in speed was over a length, and because it's over a length, that's a gradient, and it is spatial velocity. It's a change in velocity over space. So that phrase, spatial velocity gradient, is the same as strain rate, so that's true. The strain rate will be expected to be higher in the basal segments than the apical segments. That's false. Remember, what's different between the segments, say, of the septum is because the apical septum is fixed to the chest wall, so it's got lower velocities, but the strain and the strain rate, which is how much each segment contracts by and how quickly it does so, should be the same for each segment. Velocity imaging from tissue Doppler can have significantly better temporal resolution than that from speckle for the same sector. That's true because from tissue Doppler you can acquire just the spectral Doppler, very high frame rate, but from speckle you're limited to the frame rate of the grayscale image, which is always lower than a single line frame rate. Pulsed wave sample volume. The pulse repetition frequency is determined by the depth of the sample volume. That's correct, and that's, just remember, the pulse repetition frequency, how long it takes a single pulse to get to the bit you're interested to and back, and unless you're using high PRF imaging, you can't send out a second signal until the first one comes back. So often you can send them, depends on how long it takes the first one to come back, because the speed is fixed. That depends on how deep the box is, so that's true. The pulse repetition frequency is determined by the transmitted frequency. That's false. Remember, the only thing that could determine the PRF is how long it takes to get from the probe to the sample volume to back. The only thing that can affect that could be the distance it's got to travel or the speed. Changing the frequency does not change the speed. The speed of a sound wave in a given medium is fixed, so therefore that's false. The PRF will be different using a broadband transducer than with a single frequency transducer when all other settings are unchanged. That's false. That's again trying to get you to say that by changing the frequency using a variety of frequencies, then some waves will travel faster than others, and that's not true. So this keeps cropping up, trying to get you to say something will change, because what is really making you do is change the speed of the wave in the medium, and you can't do that, so watch out for that trap in the exam. The length of time in the listening phase is determined by the spatial resolution of the pulsed wave Doppler. That's correct. There's a similar question during the course, and remember the length of time in the listening phase determines the length of the sample volume. So the longer you listen, the further apart, or the longer the bit of space that the reflection could have occurred in, and therefore the bigger the sample volume. The bigger the sample volume, the less sure you are where it came from, the less the spatial resolution. The pulse wave sample can be reduced to a single point. That's false. You need to have a period of time in which you listen. Therefore, if there's a period of time in which you listen, that must correspond to an area of space that the reflection occurred in. Mechanical index is a measure of output power. That's true. It's affected by the frequency you use. That's true. So the mechanical index is affected by the frequency. Mechanical index is the power of the beam, and it's not surprising that if you've got more and more and more waves, that carries more energy than a low frequency wave. So that's true. Typically 0.1 for transpulmonary contrast imaging. That's true. That's a number you might be expected to know. It's related to the peak negative pressure in the wave. That's true. And it's related to the square root of the transducer frequency. That's also true. And in fact, these are the only two things it's related to, so it's worth remembering that. Harmonic imaging has higher signal to noise ratio than fundamental imaging, so you get more signal than noise. If you didn't know the answer, you'd say, well, it's unlikely I'd use harmonic imaging over fundamental imaging unless that was true. So even if you didn't know what that meant, probably you'd say that was true. And it is true. Harmonic imaging originates mainly from the middle of the beam. That's true. That's something you should remember. Image resolution improves compared to fundamental imaging. That's true. Higher frequency, better resolution. Requires higher power than fundamental imaging. That's true. And causes a change in texture, make thin structures appear thicker when compared to fundamental imaging. Again, that's true. So harmonic imaging, I think the physics, as we said, is quite complex. I think if you remember these facts plus the ones we talked about in the course, you'll be able to answer at least half the points, I would hope, in a question about harmonic imaging. Indications for dobutamine stress echo. So dobutamine stress echo indicating a patient who is suspected of coronary disease with a pre-test probability of 20%. If you look at the NICE guidelines and the management of suspected coronary disease, that would be incorrect. Standard dose dobutamine stress echo would be useful in the assessment of myocardial viability in patients with impaired left atrial function. That is also false, and that's false because you would use low dose. In fact, it's dangerous to use high dose stress echo with very impaired left atrial function. Dobutamine stress echo can be used to guide lesion selection for revascularization. That's true. That is to say, it's sometimes used in people who have multivessel coronary disease and angina to try and identify which territory is causing the angina, so they go and undergo focused revascularization or focused angioplasty rather than angioplasty in many vessels. Debuting stress echoes recommend the preoperative assessment of patients with coronary disease who are undergoing moderate risk non-cardiac surgery. That's false. It's recommended in patients with coronary disease who are undergoing high risk non-cardiac surgery. Debuting stress echo in patients with asymptomatic severe aortic stenosis is a recognised indication and commonly helps the clinical management of the patient. That's false. It's exercise stressing. It's exercise stress testing you would use in asymptomatic severe aortic stenosis, not stress echo. So dobutamine is a more potent stressor inducing warm motion abnormalities than a vasodilator such as dipyridamole. You would expect it to be, but in fact it's not. They're both as good as each other, so that's false. Vasodilator protocols are most useful in patients with irreversible airways disease. That's false. Many of them will stir up COPD. Patients with advanced conducting tissue disease should be offered dobutamine as a stressor rather than a vasodilator. That's true because adenosine and its friends often cause heart block. Vasodilator stress is safer than dobutamine. That's true. It's got less instance of arrhythmias. A normal stress echo, however you do the stress echo, predicts an annual death rate of about 0.5%. That's true, and that's also true for nuclear cardiology. It's also true for stress CMR. So I would there'll be some questions recently about the different stress echo protocols, and make sure you're familiar with dobutamine and vasodilator stress protocols. Is echo clinically indicated in these patients? Asymptomatic divers, no, but would be indicated in divers who had the bends or migraines or so on. So divers with certain symptoms, it would definitely be indicated, but not in divers who have had no neurological symptoms. Periodic reassessment in asymptomatic individuals with mitral valve prolapse and mild mitral agitation, no. If you read the BSc recommendations, that group of people would not be recommended for follow-up echo. Periodic repeat reassessment of asymptomatic individuals with a bioprosthetic valve, yes. There's a caveat there that you'd only do it if it was in someone who you thought you would offer further operation to. But if you've got to come up with an answer in the exam, it doesn't say that, but you've got to come up with an answer in the exam, the alternative would be to say no, and no is clearly incorrect. So I think you'd have to choose true for this. So you might come across that in the exam, where it's not quite exactly what you're looking for. A useful thing to do is say, well, what if I say the opposite? Then the opposite is clearly very wrong, so that can't be the best answer. Periodic repeat assessment of asymptomatic individuals with mechanical prosthesis, that is not recommended. And patients plan to undergo electrical cardioversion for atrial fibrillation on long-term therapeutic anticoagulation with structural heart disease but no recent clinical change. That's true, according to the BSc recommendations. Okay, the next slide is a set of numbers that I've simply lifted from the BSc posters. I've chosen them because I think there are things that are, who knows what could be asked, but I think these are the kind of things that would be most likely to be asked, and the answers are on the slide, and there's not much to say about those. You just need to know the ranges. So the LV mass calculations, if you use the wrong dimensions, then you get the wrong answer. So the first is true. You must get the right dimensions. The Dever's equation is used with M-mode images, that's correct. The accuracy of volume estimates will be similar for M-mode and 2D techniques. Well, that's false because M-mode has got much more in the way of assumption that 2D has. Eccentric LVH is most commonly seen in hypertrophic cardiomyopathy. That's false. Remember, eccentric LVH is when there's normal wall thickness but a big ventricle. A Devereux formula is most accurate in the patients with asymptomatic septal hypertrophy rather than concentric hypertrophy. That's true. That's untrue. Sorry, that's false. It's most accurate in the patient. So, in this question, it describes a patient with a big IVC with little respiratory variation. It tells you the tricuspid regurgitation velocity during systole and the pulmonary regurgitation velocity during diastole, both essentially at the start and the end of diastole. So the left atrial pressure is best estimated at 15 to 20 millimeters of mercury. That's correct. That's just a value from the BSE sheet. The RV systolic pressure is estimated at 53 to 58 millimeters of mercury, which is using 4v squared on 3.1, which is 38, and adding 15 to 20, so that's correct. The PA systolic pressure is estimated at 53 to 58 millimeters of mercury. That's incorrect, and the reason that's incorrect is because we don't know that there's not. The question doesn't tell us that there's not pulmonary valve stenosis, because if there was, then the pressure and you'd lose pressure going through the pulmonary stenosis, the pressure in the pulmonary artery would be lower. So that's wrong for that reason only. If it said the pulmonary valve was opened well, then that would be correct. The PA end diastolic pressure is estimated as 38 to 43 millimeters. That's correct, because the end of diastole, the tricuspid valve is opened, the flow has ceased, so the right ventricular pressure is the same as the right atrial pressure. And the pressure difference is 4v squared of the velocity between the pulmonary artery and the right ventricle at the end of diastole, which is the minimum velocity of the pulmonary regurgitation. So it's 2.4 squared times 4, which is 23, and then the right atrial pressure is between 15 and 20, so it's between 38 and 43. So that's true. And then the last one is the formula that's used to estimate the mean pulmonary artery pressure. So that's true. Isolated left ventricular non-compaction. It's a disease which occurs in the fetus. That's correct. This cardiomyopathy comes about because of failure of condensation of the myocardium. That failure of condensation happens in utero. It's associated with systolic or diastolic dysfunction. That's true. There's such a big crossover between normal hypertrabeculation and non-compaction that to diagnose non-compaction there has to be evidence of ventricular dysfunction. There's enhanced risk of thromboembolism. That's true. That's one of the problems with it. The other problem with it is the arrhythmias. So you'd know those two important complications. In terms of diagnosis, the non-compacted layer should be at least twice the thickness of the compacted layer. That's one of the conditions that's used, so you should know that is true. And coloured Doppler shows deep perfusion of the recesses. Again, that's one of the particular features of non-compaction. You should know the words. ARVC affects only the right ventricle. That's incorrect. About 10% of people affects the left ventricle as well as the right ventricle. And in autopsy studies there is some fatty infiltration even if the left ventricle looks unaffected in more people. Patients may present with ventricular arrhythmias or sudden death. That's true. The diagnosis is based almost exclusively on echo or echo and cardiac MR. That's false. The way that ARVC is diagnosed is very difficult. It's a hard to diagnose disease. There's a scoring system for it that involves ECG findings, family history and imaging. So it's absolutely not almost exclusively on imaging findings. Global RV dysfunction would be an expected echo finding. That's one of the things you look for. Regional RV dysfunction would be an expected echo finding. Again, that's one of the things you look at often. Regional small aneurysms. Hypertrophic cardiomyopathy affects about 1 in 100 of the population. That's incorrect. 1 in 500. Again, that's a number you should probably know. A scimitar-shaped LV Doppler trace would be expected in hypertrophic non-obstructive cardiomyopathy. That's false. The LVOT Doppler trace is only scimitar shaped if there's obstruction. Remember, the obstruction in hypertrophic cardiomyopathy gets worse as you go through systole, because as you go through systole there's more and more systolic anterior motion of the mitral valve, the muscles getting thicker and closing down the LVOT. So the further you go through systole, the higher it gets, which is why it's got that scimitar late peaking shape. It's common to see a high ejection fraction, which represents a hyperdynamic ventricle. It's common to see a high ejection fraction, that's correct. A hyperdynamic ventricle, remember, is a ventricle which starts off with a normal size and ends up with a small size and is ejecting a large volume. That's not the case here. You start with a small volume because the muscle's grown in, so you'll have a small cavity size and end up with an almost obliterated cavity. So although ejection fraction is high, it's not a hyperdynamic ventricle. It's a ventricle is struggling to keep up its cardiac output. Similarly, the function is not good, even though the ejection fraction is 90%. The right ventricle should be assessed for the presence of hypertrophy. If this is present if the free wall thickness is greater than 5 millimeters. That's correct. In hypertrophic cardiomyopathy you can have right ventricular hypertrophy, and the definition of right ventricular hypertrophy is more than 5 millimeters. SAM of the mitral valve is a finding which only happens in HCM. That's what this question is asking. That's false. It can happen in lots of other situations, including a hypovolemic circulation. So it's something you do see in hypertrophic cardiomyopathy, you see in other situations as well. Tachycerebral cardiomyopathy is usually seen in premenopausal ladies. No, it's most commonly in postmenopausal ladies. It's associated with extreme emotional physical stress. That's true. It's usually associated with reversible left ventricular dysfunction. That's true. Most commonly affects the apical part of the ventricle. That's true. And the echo finding which allows you to diagnose it, the thing that's characteristic of tachycerebral is that there's a wall motion abnormality encompassing all three coronary artery territories. So remember, tachycerebral is like a Japanese oyster pot. It looks like a flask in systole because almost always it involves the apex. The left ventricle contracts, but the apex expands. It's not just the apex, but it's all four apical segments. And remembering that the apical lateral is circumflex and the apical inferior is right coronary, and the others are usually LAD. You can see that this involves. You have to see an echo. This involves all four of these segments, so you can be sure it's multi-coronary territory. If it's not multi-coronary territory, it's much more likely to be a myocardial infarction or myocardial stunning from transient coronary artery occlusion. Mitral valve. The leaflet may be described as prolapsing if in the long axis view any part of the leaflet goes more than 2 millimeters behind the annular plane. That's true. And similarly in the four-chamber view, if any part goes behind the annular plane at all, that's considered prolapse. So you should know the definitions of prolapse. The term flail may be used interchangeably with prolapse. That's not true. A flail leaflet is where the tip of the leaflet turns to face into the atrium, while a prolapsing leaflet, the tip of the leaflet can still point towards the ventricle. The phenomenon of entrainment may cause over or underestimation of the degree of mitral cogitation. Entrainment is the idea that around the jet you make the blood vessels closest to the jet move. So you can have it overestimated with a central jet, and with a jet which is much more eccentric and runs along a wall. It can't entrain the blood around it because there's no blood around it, it's a wall, so you can underestimate it. So that's true. The vena contracta is best measured in the two-chamber view. That's false. If you think about the two-chamber view, if you think about how that's orientated usually so it cuts the smiley mouth twice. That is, it almost runs along the commissure. So really, what you're doing is the two-chamber view runs along the closure line of the mitral valve, so you're looking at it in exactly the wrong direction and can easily overestimate it. So you should not measure the vena contracta in the two-chamber view. Sinus valsalva aneurysm most commonly affects the right aortic sinus. It does. Can be congenital. Yep, you can be born with it. Can be seen around 50% of patients with Marfan's syndrome and aortic involvement. No, usually the involvement, remember, in Marfan syndrome is that flask-like aorta where all you really lose the aortic sinuses altogether, and you just end up with a flask shape. But in about 10% of people, you can identify a specific sinus of valsalva aneurysm. So it's not 50%; it's 10%. Commonly forms of fistula into the left heart when fistulas occur. That's false. It most commonly fistulates into the right heart. Syphilis is a recognised cause. That's true. Echo and acute pulmonary embolus. Echo is a diagnostic test for massive pulmonary embolus. That's false. It is a helpful test to confirm your clinical diagnosis. You can use it to help you make a decision, sort of the accepted method of making a decision about whether you should offer thrombolysis, but it's not a diagnostic test. Except in the small number of cases where you see a blood clot at the bifurcation, but even then it's not really a diagnostic test. You can't tell it's really a blood clot rather than something else. So CT would be classed as the diagnostic test for pulmonary embolus, and echo would help you diagnose right heart strain for any cause. Dilatation of the right heart filling vessels, both right heart chambers and the pulmonary artery is seen in massive pulmonary embolus. That's correct, just because the pressure is so high. Mechanical sign of dilated right heart, where the free wall looks hypokinetic but not the apex, may be seen. That's true. That's recognised and described in pulmonary embolus. I'm not quite sure why it happens, but you just have to remember it, I guess. A D-shaped septum in systole would be expected. That's true. You'd expect to see right ventricular pressure overload. The pulmonary acceleration time may be helpful. That's true. The pulmonary acceleration time can be used to look at. It can be used as a measure of afterload. That is to say, if the afterload of the right ventricle is low, when it squeezes, it'll build up the pressure. It'll build up a velocity really quickly. Whereas if the afterload is high, it will struggle to get the blood moving, and it will build up the velocity more slowly. So pulmonary acceleration time can be used as a way of estimating pulmonary artery pressure. I don't think we asked to know the values for it, but you should know what pulmonary acceleration time is. So echo and ITU, again, something that's been asked a lot about recently. In a ventilated patient with positive in pressure, the IVC diameter is smaller in inspiration. That is false, because the opposite happens. When you or I breathe in, the pressure in the thorax falls, blood is sucked out of the IVC, and the IVC gets smaller. In a ventilated patient who does the equivalent of breathing in, or insufflation it's called, then the pressure rises and the blood is pushed out of the thorax, and the IVC does not get smaller, so that's false. Low preload is identified by the presence of low cavity areas. Low preload means hypovolemia, and that's correct. Variation in the left ventricular outflow tract of 20% or more with respiration or ventilation predicts there's likely to be fluid responsiveness. That's correct. That's just something I guess is probably just to remember. The patient has been given fluid and an increasing mitral E wave with no change to the LVOT-VTI would be an indication to stop administering fluid. That's also correct, because really what you're saying is you're increasing the preload because you're still increasing the blood flow into the heart. With no change in the LVOT-VTI, you're not increasing, there's no changing afterload, or there's no change in cardiac output, so you're going to end up potentially running into pulmonary edema, so that would be an indication to stop administering fluid. And can we use to differentiate septic shock from obstructive shock? Well, yes, of course it can. In septic shock you see a hyperdynamic ventricle, and obstructive shock you see a big ventricle that is struggling to get, that's got a big end-systolic and end-diastolic area because it's struggling to push the blood through against whatever the obstruction is. 3D echo can be used to guide cardiac interventions in surgery using real-time imaging. So it's set to be used to guide cardiac interventions, and you can use real-time imaging to do that. So same way with 2D is real-time imaging. If you're scanning somebody who's has a cardiac arrest, their heart will stop on the screen at exactly the same time as it stops in the body. The same is true using 3D echo. You can use the same 3D real-time techniques now. Multi-beat imaging has reduced resolution and is doubled by stitch artifact, while multi-beat imaging means you acquire a fraction of the image each heartbeat and then join them together. So by acquiring a smaller volume each heartbeat, you get better resolution, but is troubled by stitch artifact, which is what comes from joining the different bits together. So that's false overall because it does not have reduced resolution. Compared to Simpson's, 3D makes more geometrical assumptions. That's false. The answer here is wrong. 3D makes fewer geometrical assumptions because you see exactly what the shape of the ventricle. 3D echoes the same normal ranges for volumes as 2D echoes. That's false because although you're measuring the same thing, you're measuring it better and more accurately, and the normal ranges are different. It's only possible to acquire the surgeon's eye view of the left atrium from the mitral. The surgeon's eye view of the mitral valve from the left atrium from TOE and not from TTE. That's incorrect. You can spin TTE around to have the same surgeon's eye view. Aortic arch anatomy, again, make sure you know this. There's 3 branches is true. The nominate artery branches include the left common carotid. No, the nominate artery is the first one as you come out of the heart. The first artery you bump into is the nominate artery, which then branches into the right common carotid and the right subclavian. Coarctation occurs just distal, I should say distal to the right subclavian artery. That's false. Just distal to the left subclavian artery. In standard sternal notch view, the left subclavian artery is on the right of the screen. That's correct. And the aortic dissection involves descending aorta and arch as far as the left carotid is a type A dissection. That's true. So you need to know the definition of type A and type B dissection. Essentially, a type B dissection is a dissection which involves only descending aorta, is only distal to the left subclavian. If it involves any of the great vessels or descending aorta or any other part of the arch, it's a type A dissection. That differentiation is clinically a really important one, because we've got a type A dissection, you usually get an immediate operations emergency, and a type B dissection you often don't operate, or sometimes you may stent them, and the management is much less clear cut. In moderate diastolic dysfunction, the pulmonary vein S wave should be less than the D wave. Remember what we said in diastolic dysfunction, that's when and we're looking at what happens in diastolic dysfunction, left atrial pressure goes up. The S wave of the pulmonary vein flow is during ventricular systole, so the mitral valve is shut. Mitral valve is shut, you've got higher pressure in the left atrium, so it's likely that what will happen is that during that time you'll get less flow down the pulmonary vein into the left atrium because the pressure is already high. So that's why the S wave comes down in diastolic dysfunction, so that's true. E and A wave appearances may be normal, that's true, that's pseudonormalization. The E wave appearance is highly dependent on preload, but the E prime wave appearance is not highly dependent on the same preload. That's true. Preload in this case is left atrial pressure, which has got a big effect on how the E wave appears, but actually has got almost zero effect on the E primed wave, because you're talking about a different loads affecting how the left ventricle moves. So it's not because E prime is not load dependent, it's because it's not dependent on the same preload as the E wave is. Because remember, the E prime wave is like the whole weight of the heart moving down back into the centre of the chest during diastole. So that's true. Deceleration time is helpful in identifying the presence of diastolic dysfunction. That's false, because in fact the deceleration time in moderate diastolic dysfunction is the same as the normal. And IVRT is helpful in identifying its presence. That's false for the same reason. And you should know the deceleration times and the isovolemic relaxation times for different stages of diastolic function. You should know the numbers. Agitated saline bubble echo depends on the phenomenon of resonance. That's true, we said that's how it works. Bubble contrast injection from the arm is more likely to demonstrate an atrial septal defect than injection from an injection from the leg, that should say. That's false. If you inject from the leg, question C tells you why. If you inject from the leg, the blood comes up the IVC, hits the eustachian valve. Remember, the job of the eustachian valve in the fetus is to push the blood towards the foramen ovale. So if there's an ASD, you'll be pushing it towards the hole. So it's likely to be a better test, and there's data around to show it is a better test. On release of Valsalva, there's a drop in right atrial pressure. That's false. On release of Valsalva, there's a rise in right atrial pressure, which is why when you release, you see the bubbles going across the intraatrial septum, because you release the high pressure in the thorax, and all the blood that's been queuing up waiting to get into the thorax suddenly rushes in. Agitated bubble saline echo is contraindicated in presence of intracardiac shunt. Of course, that's nonsense. That's exactly what you use it to look for, but the ones that you buy are contraindicated in the presence of intracardiac shunt, so you shouldn't be using Sonovu or Optison if you know they've got a big ASD. The reason for that is, although Sonovu guarantee that 99.99 whatever percent of the bubbles are tiny, it doesn't say anything about the size of the other bubbles, and there is a small chance there will be some very large other bubbles that if there's a shunt, they won't be taken out by the lungs, where they'll do no harm, but they could cause peripheral embolus. That's the reason why they've got that contract. And then the final question, excuse me, endocarditis vegetations. Vegetations are inflammatory infected masses. Well, that's usually true, but not always true. Therefore, I think you have to say false, because vegetations are inflammatory masses which may be infected. So things like lupus gives you sterile vegetations. Staph aureus is the most common organism, that's true. TTE is reliable in detection of small vegetations 2 to 5 millimeters. That's false. Transthoracic echo is much better at seeing vegetations over 5 millimeters. TOE is more likely to see vegetations between 2 and 5 millimeters. Characteristically, vegetations are attached to the upstream side of the valve. That's true. So in mitral valve endocarditis, usually you see it attached to the atrial side and so on. Vegetation can be attached to any part of the valve, but most commonly the coaptation line. That's true. So that's the end of the 4th MCQ exam.